My topic is recovering from non-specific low back pain, despair, ultrasound-guided intervention in Iliolumbar syndrome. Okay, source of funding nil, conflict of interest none. Okay, patients with non-specific low back pain are normally in despair due to discordance between the distressing clinical symptoms, long-standing and paradoxical normal imaging findings like normal radiograph and normal MRI. And Iliolumbar syndrome constitutes approximately 50% of the chronic non-specific low back pain of normal imaging finding. Normal radiograph, normal MRI, patient complaining of the non-specific low back pain for more than 6 months. The distinction between the Iliolumbar syndrome from the root irritation syndrome is imperative because it may avoid the unnecessary surgery. Our study was aimed at assessing the diagnostic and therapeutic role of ultrasound-guided intervention in Iliolumbar syndrome. Iliolumbar syndrome extends from the transverse process of L5 vertebrae and it attaches to the posterior superior iliac spine. 57 patients consented between the December 2017 to December 2018 for 1 year with non-specific low back pain revealing normal lumbosacral radiograph including SI joints and MRI, but iliolumbar ligament thickening more than 2 mm on ultrasound were included in this IRB-approved prospective experimental interventional study. The two-stage ultrasound-guided interventions were performed in our institution under standard aseptic precaution. One, primary diagnostic intervention, secondary therapeutic intervention. The primary diagnostic intervention was the local anesthetic test, that is the 4 ml of 0.25% bupivacaine was infiltrated in the thickened iliolumbar ligament at posterior superior iliac spine level under ultrasound guidance. The assessment was done by clinical pain scoring both pre and 72 hours post using the visual analog score, and the respondents to the primary intervention when the visual analog score was less than 3 were considered to have a confirmed diagnosis of Iliolumbar syndrome. That means the Iliolumbar syndrome, iliolumbar ligament, thickened iliolumbar ligament is the pain generator. Those patients, those respondents who responded to the local anesthetic were further managed with a 4 ml of platelet-rich plasma injection, which was prepared by the 20 ml of the patient's blood with single spin 1800 RPM taken for the 7 minutes under ultrasound guidance, and it undertaken by the standard protocol. And the assessment was done by both by the VAS score and by the thickness of the iliolumbar ligament on ultrasound as 6 weeks after the platelet-rich plasma injection. So here is the thickened iliolumbar ligament, this yellow star, the thickness more than 2 obviously 2 mm. Normal thickness is approximately 1 to 1.2 mm. Erectospinal muscle, subcutaneous fat. This is this shark fin appearance. This is the posterior superior iliac spine, transverse process of L5. The ligament extends between the L5 transverse process to the posterior superior iliac spine. The intervention was done under the real-time ultrasound guidance. The needle was inserted and it was pointed towards the posterior superior iliac spine, not towards the L5 transverse process. And the target was reached until unless this needle touches the bone. Then it is confirmed that we have reached at the attachment site of the iliolumbar ligament at posterior superior iliac spine level. Results. Out of 57 patients of non-specific low back pain having normal radiograph and MRI but thickened ILL on ultrasound, 78.9% were diagnosed with Iliolumbar syndrome on primary diagnostic intervention on local anesthetic challenge. VAS score less than 3 after 72 hours. All 45 patients underwent ultrasound-guided platelet plasma injection, 4 ml, in the iliolumbar ligament at posterior superior spine level. And out of this, 93.35% showed the significant improvement on VAS scale as well as the reduction of the iliolumbar ligament less than 2 mm after 6 weeks. And this is the chart for 57 patients of non-specific low back pain after primary diagnostic intervention. 78.9% were respondent, means in that case, the iliolumbar ligament was the pain generator. This is in contradiction to the previous literature of 1993, in which the 50% of the non-specific low back pain was because of the thickened iliolumbar ligament. Secondary therapeutic intervention by platelet-rich plasma of 93.3% patient responded to the platelet-rich plasma. The limitation of my study was the interval between the primary and secondary interventions was not specified in this intervention study. Second, long-term follow-up is obviously needed to prove the clinical feasibility of this study. Conclusion, ultrasound-guided diagnostic and therapeutic intervention using long-acting local anesthetic and platelet-rich plasma respectively were found to result in remarkable recovery in Iliolumbar syndrome group of patients with non-specific low back pain, and the potential of further exploiting this management strategy in patients of low back pain living a life in despair obviously needs no further emphasis. Thank you.